Our final panel today focuses on one of the most pressing issues in cancer care, and that's equity in the Black community. Leading today's conversation is Tam Hawkins. Not only is she a leader in business, she has some personal expertise in this space. She is joined by three equally amazing women, Dianne Austin, Sylvie Leotin, and LaTashia Kiel. Tam, the gallery is yours.
Thank you, Suzanne. I'm really delighted to be here and join a panel of such amazingly incredible women and the way they've approached challenges and the space with creativity and ingenuity, quite frankly. So today we'd like to start this conversation by kind of level setting and talking about the economic impact on the disparities for Blacks facing cancer. For African Americans on average, each cancer death resulted in 19.7 years of lost life and roughly about $232,000 in lost earnings. And for white, in comparison, that number was 17.2 years of lost life and annual loss wages of $175,000. In 2015, that disparity meant that the African American community had an additional 241,000 people lost in life with a revenue of $3.2 billion lost in earnings. We've known also since the 1960s, Black men and women have had higher cancer mortality rates more than their white counterparts. So on the one hand, we may have conscious or unconscious medical provider bias. And on the other hand, we have a sweeping justifiable distrust of those same providers. I'd like to ask my panelists, which I am remiss in not introducing in a better way, about what can be done to decrease that mortality rate. But before they answer that, LaTashia Kiel is co-founder of Kiel Colon Cancer Foundation. Hi, LaTashia.
Hi.
And then we have Sylvie Leotin, who is a consultant who's done phenomenal work in patient advocacy and research. So welcome, Sylvie.
Hi, everyone.
And then finally, we have Dianne Austin, who is a co-founder of Coils to Locs. And just amazing work by all three ladies. So welcome, ladies.
Thank you.
And I'll repeat the question a little bit. We were talking about mortality rates, and we're talking about unconscious bias, maybe in distrust of the medical community, affecting some of those mortality rates. What do you think may need to happen to increase our efforts and decrease those rates?
I think for starters, we need to move to a system where we actually look at healthcare that cares. Right now, our system is set up in a way that prizes making money, it prizes innovation and technology and efficiency, and those things are good things. But then what ends up happening is you have providers who are trying to care for patients, but when they get ready to walk in a patient's room, there's this clock that's ticking inside their head. And so what ends up happening is they're not there. They're providing healthcare, but the care part of it is what's missing. And so I personally think that it starts with love. And I don't know how to teach that though. And so I think that is where the conversation needs to start, because guess what happens when you love someone? And when you look at the patient and the family members that you're providing care for with love, you try to get to know them and understand them. And so that care tends to look a little bit different than what we're currently seeing in our healthcare system.
So Tam, I'd like to offer my perspective on your question as well. It's so important, and I believe that there is data that shows that Black patients really resonate with seeing healthcare providers that look like them as one way to impact healthcare outcomes. And it goes a long way in building trust because of the negative experiences that Black and Brown people have had in the healthcare system traditionally. There's also data out there that shows that Black patients' healthcare complaints are not taken as seriously. And we're not always provided the same level of access to tests, for example, that can impact our health outcomes. And the list goes on and on. So another way to build trust would be to ensure that there is an ongoing and actually practically applied cultural sensitivity training of physicians and I think other healthcare providers so that they can understand their own unconscious bias and be sensitive really to the issues such as how social determinants of health plays a role in why a patient is not taking their medication, for example, or that Black people disproportionately work in fields like the service industry where the salaries are lower and there may not always be access to health insurance. And that impacts your ability to get regular checkups or even pay for prescriptions. So I think we need to understand the big picture if we're going to make an impact in mortality rates.
Oh, excellent. Sylvie, do you have anything that you wish
I would like
to add?
And comment on a couple of things that LaTashia, I loved your comment about love and care. I was listening to the Livestrong keynote this morning, and Duncan was mentioning that at Disney they are considering not customers, but they are looking like they are guests. And as I was listening and I was thinking, my God, what would it be to be a Black patient treated as a guest in a hospital? I'm a recent cancer survivor, and I certainly did not feel like this during my treatment. I wanted to also talk about the bias. I really think that and there are studies now that are showing that directly racism and racial bias are the cause of disparity. It's really and it's perpetuated today in bias provider-patient interaction between Black patient and white physician. There was a recent study that Genentech just published a few weeks ago on equity, and they found out that only 27% of Black patients think that they are treated fairly in healthcare today. 27% only.
Well, that's a staggering number. And it reminds me of a study about right now we're seeing research go into the effects, the mental effects of racism and how it plays roles in your physical health as well and how it shows up. So I'm excited to see research being done on that. And then that leads me to kind of my next question about this. And I have to say, you guys are just a phenomenal panel. And I didn't say that, LaTashia is a nurse practitioner and patient. Did I not say that?
No, I'm not a nurse. I'm in school to be a nurse practitioner. I'm a nurse and a professor, but not a nurse.
I'm claiming it. I'm claiming it. That's
I appreciate that.
Dianne and Sylvie are recent survivors, and so what I'm getting at is, we've had a deficit of. Dianne just spoke about a deficit of Black doctors and nurses and researchers, right? And so we've had that deficit and we haven't seen just this focus necessarily on care from a cultural standpoint. What do you ladies think that we might do differently to improve those outcomes and make certain that we have people that can relate to the patient in front of them?
I will start this time. Yes, there are only 2.3% of Black oncologists in the US. There haven't been studies in cancer specifically, but in general healthcare, there were studies showing that, Black babies are 3 times more likely to die if they are treated by a white doctor. I personally received my cancer treatment in a white hospital, one of the top cancer centers in the country. And I really was the only Black patient, and I haven't seen a single Black physician. So actually this week, there is a really exciting event happening on Twitter. It started last Sunday, and it's called Black in Cancer Week. It's been started by Black researchers, PhDs and students in cancer research. And they have started this movement all around the world to really increase, bring attention to increasing the pipeline and being able to produce more Black doctors and more Black researchers, because even, we know that there are a few Blacks that are going in STEM, but even those that are in young position in cancer research, they're really struggling to be promoted, to become doctors or to become cancer researchers. And all of this because of bias. So they're really igniting something really exciting. They were on the cover of Forbes Health a couple of days ago. So one thing is to really promote, Black students to become doctors and to become cancer researchers. That will be very important. But I think equally important is to really address the problem that Diana was alluding to, which is racial bias. To date, there are not any racial bias really programs that have been in place for, definitely not in oncology. I'm developing one, but in a lot of the programs have been actually geared towards medical students and residents. But we know that, oncologists are the ones that have the relationship with the patient, and also they are seen as models from young students. So if the oncologists have a biased role, it's not going to, train young students to do better than them in that capacity. So I really see that racial bias is the root of the problem, both in patient-physician interaction, in interaction between white young doctors and white doctors. And also, I will talk about this more in the design of medical processes that are really not racial friendly.
Well, either ladies, would you like to comment?
Sure. To piggyback on some of what was already said, I think that we can really make an impact and increase the numbers of Black people in the medical field in a number of ways, but I think it really truly starts with investing in our children and at the elementary school age level. We need funding for high quality in-school and after-school programs that are centered on the sciences that will expose kids to medical professions and these professions, but also to professionals of color, and in particular to healthcare careers and the sciences, so that it doesn't feel like a foreign topic or an unattainable goal to be in the medical field.
And I'd like to add to that, kind of again, piggybacking off of what both of you guys have already talked about how important it is to empower this next generation. Because personally, I don't think they think that they can do it. I'm currently mentoring a student right now, a high school student, and I'm sure she wouldn't mind me telling this story. But essentially, she reached out to me and said, "Hey, I want to get into nursing school. I'm first generation. I don't really have an idea what I'm trying to do. And so can you help me?" And I'm like, "Sure." And so I'm talking to her. I'm like, "Why do you want to become a nurse?" And she's like, "Well, I'm interested in like the interaction and like the way the nurses like talk to the patients and that kind of thing." And I'm like, "Yeah, but you didn't answer the question. Like, why do you want to become a nurse?" So like, I get the interaction, but what is it about you that makes you think that this is the correct pathway? You know what? Tell me what you want to do after you graduate. What do you want to do with your nursing degree? And she said, "Well, once I graduate, I'm going to go back to medical school and so I become a hematologist, oncologist." And I'm like, "What? Okay, whoa. Let's go back here. Like, what's the ultimate goal?" "I really want to be a hematologist, oncologist." And I'm like, "So why are you trying to come into nursing school?" "Well, that's, my fallback plan." And I'm like, no, this needs to be the plan. Like, if this is what you're going to do, we're going to go for that. And I'm a nurse, you guys. I love nursing. I promise you, I'm not ever going to talk anyone out of that if that's what you want to do and it's the right step. But I'm like, no, you can do this. And this doesn't have to be the fallback plan. Like, you have to go into it. You have to commit to it and know that this is it and go for it. And I just don't know that they absolutely truly believe that they can do it. And so again, going back to Dianne, what you said, we have to start early to get these conversations going, to put examples out there, to let them see and know that it is attainable and that they can do it.
Oh, I love this. And I'm just going to recap what I heard. It was so good because it was full circle, right? It was here at the end product and result in terms of training and research and exposing, your conscious or unconscious bias and helping professionals already in the field kind of navigate that. And then I also heard we have to improve investment. And you didn't say this, Dianne, but I'm going to say it. I heard policy. I heard soundly policy improves investment and policy coupled with private investment, right? Because it doesn't have to all be a government. And then LaTashia, I also heard mentorship with you and making certain that students and young people understand their pathways and what options are available to them and getting good sound coaching, right? And saying, hey, you don't need to go that path. This is an incredible conversation. And that being said, I want to talk a little bit about the impact of COVID-19 in terms of care and treatment. We've seen some of the rollbacks with cause, right? With good reason for patient advocacy. And I just remember when we were going through my own personal journey of being grateful for being able to have my family. I had two little ones as they watched my husband struggle with cancer, and he was able to be surrounded by family that loved him. But my concern with the pandemic right now is, are we going to see long lasting implications from some sound sanitary practice to protect patients and advocacy for cancer patients in particular? And what are your thoughts on that? I don't expect you to be experts. I just, with your own journeys, if you could just provide some of your thoughts on that.
Sure.
LaTashia,
I'm sorry.
Dianne.
Go ahead.
I couldn't tell. Dianne, go. Okay, we're all. Dianne, go ahead.
Okay. And I'm sorry, I sort of jumped in there because you touched on a few things that were in my thoughts around this. I really would like to just answer the question by sharing a few personal examples of how COVID has really reshaped the way patients and families interact in the healthcare system. Family is very, very important within the Black culture. And when someone is sick, we all rally around that person. And part of the rallying around that person is being in the hospital room as a family with a sick family member. And I really don't mean just like one or two people, but it's always like this ongoing entourage of people that are coming and going. I think you can relate to this, or, sitting with that sick family member until we're like kicked out of the hospital room. And I recently lost two very, very close family members in a 3-month period, just a short time ago. And we weren't able to sit with them and talk to them and be physically there for them as a collective group. And certainly not for more than, I think it was like an hour a day in one case. And I believe that the ability to be with family members in the hospital can play a role in their recovery, or allow that loved family member to know, like in their last hours, that they are loved and not alone. And COVID has increased the need for social distancing, which has impacted the personal touch related to patient care. And in some ways, I believe in outcomes. It's been it's very, very difficult.
I will add to this something. I see the question from a different angle. Thank you so much. You made a great point, Dianne. But I see, as a cancer patient, and advocate, I've been really looking at the data on how COVID is affecting cancer patients, and We've seen 46% decrease in the number of cancer diagnosed since COVID started. The NCI has also estimated that there would be an additional 10,000 cancer deaths in breast cancer and colorectal cancer due to COVID. All those delays in both screening, in treatment, a lot of surgeries have been postponed. And so this is having a really big impact. There is another big thing that we see with telehealth, right? So we're moving to telehealth, and that's really exciting. I certainly have taken advantage of it, and I really enjoy it. But I can also tell you that for my new company, I'm a CEO of Equify Health, starting a company to decrease health disparities for Blacks with a diagnosis of cancer. I've been interviewing Black patients around the country, and a couple of things is that, many Black patients are actually not using telehealth, whether they don't have broadband access or they are not comfortable with this technology. So I spoke to a cancer patient with prostate cancer, for example, and he has not seen his oncologist for 6 months because he just can't figure out how to use telehealth. So there is really an impact on the care that Black cancer patients are receiving. Also, as the Black patients and survivors, we are, some of us, many are immunodeficient, and it's been shown that, Black patients are twice as likely to be diagnosed with COVID cancer patients. So I think that COVID is definitely negatively impacting the Black community. We know for the COVID mortality rate, but the Black cancer community is really deeply affected by COVID. And we do not have the numbers today, but the projection that I was talking about, 10,000 extra Black deaths from cancer patients in just 2 cancers alone. This is huge. All those delays are going to cause some major problems.
Yeah, just not delays, right? We're also seeing that COVID patients will have experience they're more likely to have mortality rates as a result. And so thank you for bringing back the technology gap as well, Sylvie. And Diane, I just wanted to take a moment to tell you that I'm really sorry for your losses
Thank you.
during this time. And LaTashia, is there anything that you wanted to add to this discussion about how you COVID-19 might impact patient care?
Yeah, the thing is, when I think about the whole treating the whole patient, and not simply being this acute disease, the thing that screams to me is prevention. And when COVID-19 hit and America pretty much shut down, it was like only things that are essential, right? And obviously, I'm the Kiel Colon Cancer Foundation, and so my interest is specifically in colon cancer. I mean, what we ended up seeing in the colon cancer community is that colonoscopies are not essential because all of them got postponed, right? And so we've worked so hard for so many years to tell people how important colonoscopies are, and you have to have this screening, this prevention, so that we don't get to this place of this acute disease. And then all of a sudden COVID happens, and they're like, it's not that important because it's not essential. And it's like, oh my God, so where do we go from here? Because now you pretty much made it, you made the point that it's not that important. And so I kind of feel like all of the work that has been put in there is essentially like starting all over. And so, and just for the record, people are not lined up around the corner and banging down the door to get colonoscopies. And so there's a lot of work that has to go into, getting the information out there, raising awareness, and having people realize how important it is. only for COVID to happen and it to be considered not essential. And so now you have people whose diagnoses are being prolonged. And so now, unfortunately, they're getting diagnosed at later stages. Screening is not happening. So colon cancer is beatable, it's treatable and preventable, but it has to happen before the polyp gets to the point where it's actually turned into cancer. And so now we've postponed colonoscopies now for how long, moved them out because we stopped doing them for so long. And so there definitely is going to be an impact. And we've already started to see that. I work with a couple of organizations, the Cancer Alliance of Texas, and we're currently working on like, how do we at least get back to where we were to move forward because this COVID-19 has really pushed the work that we've done back.
LaTashia, I wanted to, I find your work really fascinating as well, because it reminds me of the early days of breast cancer research and how we had to, go over such hurdles to start that research. So your work reminds me of that. And along that vein, there's been a lot of discussion during a pandemic surrounding colon cancer, given that, Black Panther Chadwick Boseman passed away this summer from the disease. And you found a culturally relevant way to bring awareness to the disease, to the Black demographic. Can you talk a little bit more about your work in your foundation and what really needs to happen to support your foundation?
Yeah, so one of the things that we did when we first learned about George's mom being diagnosed with colon cancer is obviously no one in our family had ever been diagnosed with any type of cancer. And so we were just like, oh, we need to get out here and try to learn as much as possibly can. And so again, one of the first things that we found out is that it's one of the most beatable, treatable, and preventable. And we're like, how did we get here? How did we miss this? And so it was devastating. We, again, got out there and just tried to learn everything that we could possibly learn. And from there, we went out to start educating other people about it. As far as our nonprofit and what when we were, I guess before we started the nonprofit, actually, we were looking at other nonprofits that exist already to try to see what help, what support was out there so we can maybe join in with some other groups. But what we found is that, again, going back to what Dianne said about how important it is to have people that look like you, what ends up happening is, so colon cancer, for example, used to be considered this old person's disease. The most recent research has shown that colon cancer has been diagnosed in people younger and younger ages. In fact, the American Cancer Society came out a year or so ago and asked that they put information out there, data that supported lowering the age from 50 to 45 for screening. And the thing about it is, though, when you say colon cancer is no longer old person's disease, but then you look up at this billboard and they're like, oh, you should go get a colonoscopy. And they're like all older people on the billboard. Younger people don't look at that and say, they don't resonate with that. And so one of the issues I was having is that, we have someone in our family that we love that has colon cancer. It increases the chance that my husband, for example, may get colon cancer because now he has a first degree relative that has had it. But then when you go out there and you look at the other organizations who are talking about it, who are advocating and promoting it, they don't have anyone that looks like us. And so now it's just kind of like, are you guys really talking to us? And then when we get out there and we're trying to send this message, I just didn't find anything that resonated well with me and my family. And so that was why it was really important for us to start our foundation. We decided that the best way to do that was to go to where the people are our age, because we're young and young people are getting diagnosed with colon cancer more frequently. And so where are young people? They're on social media. So we started an Instagram page and we got into Facebook and everything with it. And it just kind of grew from there. And it was really interesting because now you started seeing these other nonprofits who had been around for years calling us going, hey, we've been here for, X number of years and we have like this many followers and this much engagement. Like, how are you getting all these people to kind of like jump on y'all's bandwagon and like listen and be active? And so I think it was just, again, seeing the gap there and just trying to jump in there again, because what's important to us was that we needed this message. Where was the message for us when we needed it? Because maybe it would have helped us not lose my mother-in-law.
Thank you for sharing that. Dianne, I wanted to direct my next question to you. Your own personal experience made you identify a gap in the marketplace in a $3 billion Black hair care marketplace, to be specific. Tell me a little bit more about that process and share if it's been a cathartic journey for you or not. I'm excited to hear more about your company, Coils to Locs.
Absolutely. And thank you for the opportunity to just share this part of my journey, because Coils to Locs was developed based on my experience as a cancer patient. I'm a breast cancer survivor, and I was diagnosed in 2015 with breast cancer and was told I would need surgery and chemotherapy and radiation. And part of that treatment in terms of the chemotherapy would mean that I would lose all of my hair. And I wear my hair in its natural state, which is unstraightened. It's coily, curly, kinky, so many different descriptors for it. But this is my hair. And so I was given a wig prescription by my oncologist, from my oncologist. And he said, you know, you can go to any cancer center boutique and get a wig. And I'm blessed that I have very, very good health insurance, and my health insurance covered the cost of this cranial prosthesis, as it's called. And I went to the place where I was being treated, not thinking in a million years that I could not find a cranial prosthesis that looked like my hair. But in fact, all I could find were straight-haired wigs in this boutique. And I live in the Boston area, so I went to all of the major cancer center hospitals that had these boutiques and could not find these wigs anywhere. And it was frustrating. So my journey was, I have to tell you, was frustrating, because it was hard for me to believe that no one in the Boston area sold these wigs. So it was denying me the opportunity to use my health insurance. So I consider it a health care disparity. And my sister and I called across this country, called cancer center hospitals across this country, major cancer center hospitals that had these boutiques, and asked if they sold these wigs, and nobody did. They would refer me to medical salons, and they didn't sell them. And so the business was started based on, quite frankly, my frustration of not being able to get the same level of service as other cancer patients, and my interest in solving a problem so that other people would not have this problem. And, you know, I've had conversations with individuals who are in this entrepreneur ecosystem, like investor ecosystem. And oftentimes what I hear is, well, it's just a wig. Can't you get a wig anywhere? It's not just a wig. When you are in the process of losing your hair, you're fighting for your life. In many cases, for, you know, depending on how severe your cancer is, you want some sense of normalcy. You want some control over your life. You want to be able to look in the mirror and not, quite frankly, be depressed. And part of that is something as simple as being able to get a wig that looks like the hair that you've lost. And so this is the journey that my sister and I have started to really ensure that we fill a gap that is missing unbelievably in the healthcare market right now for Black women, and quite frankly, any woman who has very, very highly textured, curly, kinky hair.
Oh, wonderful service. Sylvie, I will ask you about, you know, you've done really good work at exposing your vulnerability and what you experienced as a patient, and in patient advocacy and research. What surprised you the most about what was missing from the equation? And can you tell me a little bit more about how you and your company are bridging that gap?
Yeah, thank you for your question, Tam. Yes, so as a cancer patient, when I was going through cancer treatment, I was shocked to see how little the healthcare industry and the people in the hospital were really understanding the patient experience, the cancer experience of the patient. I found that, things that were very simple were made very difficult. So I started to share my frustration with my doctors and cancer support groups and everybody, and ideas or where I saw the problem and how to fix it. And my doctors were telling me, wow, you are educating me on the cancer experience like I had no idea. I've been in this field for 20 years and you're the first cancer patient that makes me understand what it's like to go through radiation. So everybody encouraged me to write a blog, and I started to write a blog about my experience, and also wrote an article about my treatment and how to improve it from the perspective of patients. And my article got very successful. It got, I think it's getting close to 2,000 downloads, and all my doctors have loved it, and I just get thank you email from all over the world about how I'm helping radiation therapists and radiation oncologists do a better job for cancer patients. My blog as well has just taken a life of its own. It's read in 100 countries. My last post was about how lonely it feels to be a cancer patient. It was called "Cancer is the Loneliest Place." And it got 4,000 shares, which is huge. Like the average number of shares of New York Times article is 1,000. So I found that I really had a gift to articulate the deeper layers of the cancer experience that people that don't have cancer don't know. And that can help both, caregivers and family members to better understand the experience of cancer and deliver better treatments. I think this gift is coming from different things in my life. I'm a mindfulness practitioner. I meditate twice a day, so I'm very observant of every single detail that happens around me, and I could do that in my cancer journey, going through the hospital. But also, I have a career in my French accent comes out in technology and in innovation. And so, when we are developing new products, the first thing that we do is to try to really understand what it's like to be in the shoes of the customer. And I think that the healthcare industry is talking about being patient-centric, but I don't think that they are patient-centric to the level of really being able to see the patient experience from the inside out. So when you see how there is this gap between non-cancer patient and cancer patient in understanding the experience and providing the right services, you lay on top of that racism and being Black. And it's just like, you're a Black patient, cancer patient, no one in the healthcare industry is going to understand what you're going through. And, I have interviewed Black patients with cancer who have told me that they would never talk to that person again. And that person is their oncologist. They've been so traumatized and treated so disrespectfully that they do not want to see their oncologist again. And that really pains me deeply. Like when I interview people and they share those stories, like I was crying last time, when you see, because I'm a cancer survivor. I'm just actually a very young cancer survivor. I was just diagnosed 2 years ago. So I still have the pain of my cancer journey is still healing. I mean, it's going to heal my entire life, but it's still very close for me. And I know what it feels like to have cancer and to have lost everything. You lose your health, you lose your relationships because people can't understand you, you lose your identity, you lose your financial resources. We all know that cancer, the toxicity of cancer. And you're losing your physical strength, your emotional strength, your mental ability, everything. And so when you are in that situation and you are experiencing racism or bias, it is devastating. It really is devastating. And I can talk more, Tam, but I don't know, maybe you want me to stop and let someone speak and then I can come back, because I can just go on and on this topic.
Yeah. So moderating panels online has been just a very unique experience, to say the least, for me over the last few months. But thank you so much all for sharing very what I find intimate details about the work that you do. So I'm in awe and gratefulness of you sharing those journeys. Now I'm going to pivot to a question about policy, and I keep focusing on policy because I believe a lot of, for me, let me say this, a lot of my work has been in dismantling systemic racism systems, right, and practices. So in this country, one of the gravest injustice with that practice was started in policy. So I believe, and maybe naively sometimes, that policy can eradicate that and dismantle it as well, right? Can't be done all by itself. Policy alone won't change it. It's the hearts and minds of people. Otherwise, what do you think, or what would you hope in the work that you do to influence outcomes on cancer treatment for Black people specifically? I know we've kind of danced around it, but if you have anything else that you want to add to that part of the conversation, I know there are a lot of people who are interested in learning that.
I can start, and at the risk of sounding redundant, you know,
kind of a redundant question, right?
No. But my response is probably going to be, but Coils to Locs is centered on ending an overlooked healthcare disparity, and so I'm going to talk specific about my space, and you know, it's the lack of these ethnically inspired wigs that can be purchased at health insurance with your health insurance. And you know, medical wigs, they're more than just a vanity item. And you know, when you're faced with a healthcare diagnosis that drastically changes your appearance, beyond hair loss, your skin grades, you're tired, your nails block, and sometimes they fall off. All of these things, you want to maintain some type of sense of self and as much control as possible. And I remember a well-respected physician at a major hospital in Boston shared with me that there are women who will actually forego chemotherapy if they know that they will lose their hair. So think about the potential outcomes for a patient who refuses chemotherapy. So as self-serving as I know this is going to sound, if I could influence policy changes in relation to the work that I do, I would influence the decision makers at healthcare institutions to look at the services and resources that they are providing through a culturally sensitive lens, through an equity and inclusion lens, and actually require that they ensure that the products and services that they offer meets the needs of all of their patients. And so that would mean as something as simple as having a medical device, a coily curly wig available to a patient that may want that, or whatever that may be. in the medical space.
I think that's a wonderful response, and I didn't think it was self-serving at all. You're helping a lot of people. Really, you are. You're truly helping a lot of people. Anyone?
It's hard for me to.
I think you might be muted, Tasha.
Okay.
Oh.
And I'm sorry, LaTashia. I've been practicing hard not to call you Tasha like your family.
Oh no, everyone calls me Tasha, so that's totally fine. So the thing, I have a policy, but it affects another policy. So essentially, I think in order for us, and kind of to go back to what I talked about earlier, healthcare that actually cares. I think that one of the things that on the policy side that needs to happen is that we have to change the way we fund healthcare providers. And so we can't have it to where the providers are paid depending on how many patients they can see in an hour. Because what happens is they don't actually see the patient, you know. And I think once that happens, I guess the downstream effect is if now I'm spending more time with my patients, so I'm actually seeing them, getting to know them, loving them, to make sure that they get the care that they need, that decreases the number of patients I can see, right? And we already know from research that primary care providers are at a shortage. So then if we were to go and change this policy that changes the way providers are funded, and so now I'm taking the time to actually care for my patients, I'm seeing less patients. So now what happens to the patients who need care that they can't get in to see me? So that's where the second part of the policy comes in. And that's where I feel the advanced practice providers, an example of nurse practitioners, they need full practice authority. Because again, we need to have more providers. We need to have providers that have time to actually care and see these patients. And then that goes back to one of the topics that we talked about before, about the screening app, about being screened and how important it is for people to look like you, to speak the same language, to understand your culture and your background. But then there's a study that came out not long ago that talked about how patients were most likely to get screened when their primary care provider suggested it. But guess what happens when I only have 10 minutes in this room with you? You know, if you bring up a question about something else, that screener that I would have recommended, I forgot about it. And so now here we are. And so when you want to talk about the community of the African-American community and how do we get better? How do we provide care that's appropriate, that gets to what we need? I think there are two ways that we could help policy-wise to make that happen.
Wonderful. Sylvie, did you have anything you wanted to add to that?
Yes, I mean, I just like Dianne, to the risk of sounding redundant, I'm really going back to racial bias and cultural sensitivity. I think that, you know, we have a healthcare system, a cancer system that's making incredible advances and made incredible advances in the past 40 years, but they have not benefited Black patients and underrepresented minorities, because you know, everybody is focused on reducing the problem to patient-provider interaction. But that is a small part of the problem. I think that as someone who is a design thinker, who has been in innovation for 20 years, you have to start understanding the person that you're building policies for, that you're building products for, that you're delivering services for. If you don't have an understanding of the Black patient or the Latino patient, if you don't have an understanding of what are their barriers and how they experience cancer, you cannot just create this one-size-fits-all solution and hope that everybody is going to take it. Look at what's happening with COVID vaccine. It's just a starking example that they haven't been able to enroll the people that need it the most because it was designed as a one-size-fits-all kind of strategy. So I think that, and this is really what my company was built for, is to really help the industry understand the cultural experience, what it's like to be a Black patient, a Black cancer patient, a Black COVID patient in the healthcare system, and what are the things. That is the only way to be able to have a vision of the Black patient that doesn't have projections and bias and filters. Otherwise you keep building products that are not going to reach them. So this is what I'm fighting for. This is what I stopped my job to do. And this is really what I think, I didn't answer your question earlier, Tam, when you asked me about what's the hole I've seen in the industry. And this is the big hole that I have seen in the industry, is that there is a lot of money that's being put at solving disparities, but not so much attention in really understand what is the lived experience of Black patients, of Latinos patients. This is not being understood. Just listing a numbers of minority, of disparities, this is kind of just observational studies that are very important. Now we know the impact, but if we don't know what it's like to be a Black patient, if we do not have what I call cultural empathy and cultural sensitivity and cultural curiosity, we are not going to solve this problem. So that's the problem that I'm hoping to solve with my company. Thank you.
Thank you. I think we've really explored some important topics and just different ways of kind of attacking them. I'm going to ask you, ladies, a final question. It's kind of probably summing up what you've already stated earlier, but I believe each found profoundly creative and innovative ways to fight cancer, and with particular focus on the Black experience of it. So what is the one thing that you'd like for us to know to help you to continue to do your work? And here I'm asking for you to be unabashedly self-serving, like whatever it is that you need to do your, I am. And part of it is because, again, my charge in what I've done in my career, it is make certain that I promote entrepreneurship, make certain that people have the tools that they need to be successful. And if we don't talk about it or ask for it, we won't get it. So that being said, anybody want to take the first stab of that? Or I can call on you like they do in school.
I can take the first stab. I would say two things. One would be, if you're out there in the audience and you are in any way connected with a cancer center hospital that has a cancer center boutique, we would love to be able to get connected to the influencers who will help us get our wigs into your hospital. So I would ask that you reach out to me at daustin@coils.com. If you're an investor, I'd love to talk to you because we need help in really helping to end this healthcare disparity. So those would be my two asks. And you can go to coils.locs.com to learn more as well.
Good. Sylvie?
Hey. Oh.
Okay. Whoever.
I will share my with you. Thank you very much for the opportunity, Tam. So as Dianne, I'm starting a company and still in the process of looking for funding. I'm applying for grants and also looking for funding through a relationship. I would love to be working with pharmaceutical and biotech companies. I have relationship with some, but if anyone in the audience is in that space, would love to speak with you. You can find me at equifyhealth.com, EQUIFY health.com. And also, I've developed an innovative training to help people understand what it's like to be a Black cancer patient. It's never been done before. It's really innovative and disruptive. And if you would like to pilot it, would love to talk to you. Thank you.
And I would say, I would say for us at the Kiel Colon Cancer Foundation. So when we first started our foundation, we were babies. We had no idea what we were doing, and I felt like we had some very early on successes through our social media channels. And what ended up happening is a lot of the organizations that were already in that space reached out to us and started trying to connect. And I was thinking, oh, synergy. We're all going to work together, and it's going to be great. And now they'll see people that look like, my community will see people that look like them and resonate a little bit more with this conversation. But what we ended up finding out is that what was missing was the genuineness in the conversation. And so I don't know, I kind of felt like we were kind of being used as props and tokens, and not necessarily being taken seriously and wanting to actually be a part of the community. And so just kind of seeing us as equals. And so I guess a ask for us would be some of those same things. We are in the process now of relaunching our foundation. And so we'll be up and running again in 2021, officially in a new capacity where we're focusing on not only advocacy and education and awareness, but also focusing our energies on the grief and hope. Because that's something that's been really important to us in our own healing throughout this entire process with our families. And so donations, funding, volunteers, all of those things, we need all of those. I would say expertise. I think a lot of times, especially with us being very new into what we're doing, people don't want to help. And it's just like, I don't have all the answers. And so if you see an area that you feel like we're lacking, like reach out to us and help us out. And so that would be specifically what I would be asking for. And so you can learn more information about the Kiel Colon Cancer Foundation at kielcoloncancer.org. And that's Kiel, Kiel.
Oh, thank you, ladies. It has just been the best part of my week. And I'm so happy to get to know you and have this conversation to highlight some disparity and some innovation and some hope. So I love that you said that, LaTashia, hope and in progress. So nothing that we can't conquer, correct? Thank you again. Suzanne, thank you so much for allowing me the opportunity to be here as well.